Going to do our grand rounds today on clinical applications for ketamine for mental health in children. Dr. Cullen is an assistant professor in the Division of Child and Adolescent Psychiatry in the Department of Psychiatry here at the University of Minnesota Medical School. She is a native Minnesotan, having completed medical school, residency in general psychiatry, fellowship in child and adolescent psychiatry, and a research fellowship, all at the University of Minnesota. The majority of her research has been dedicated to studying the biological underpinnings of depression in adolescents. These projects have been supported by her T32 Research Fellowship and by her National Institute of Mental Health K23 Career Development Award. Part of her current work is supported by the Center for Translational Science Institute grant. This project is Intravenous Ketamine in Adolescent Treatment-Resistant Depression, Efficacy and Brain Mechanisms, which examines neural circuitry before and after ketamine for adolescents with depression, and is the topic for today's grand rounds. Please join me in welcoming Dr. Katie Cullen.
Thanks, Mark. Thanks very much, Mark, for inviting me to give this talk, and it's a pleasure to be here in pediatrics. So I'm Katie Cullen. I'm a child and adolescent psychiatrist, and like Mark said, I've been focusing on mental health in children, and especially depression in adolescents. And ketamine is a relatively recent area of research for me, and it's been actually great to be able to collaborate with Dr. Roback, who has more experience using ketamine in children. So that's what we'll be talking about today. I went too fast. I don't have any conflicts to disclose. These are kind of my research funding and my employee status. I guess I should say that ketamine, I'll be talking about the off-label use of a medication or a drug, ketamine. All the applications are off-label. So today I'll begin with just discussing some background and basic information about ketamine, its role in anesthesia and procedural sedation, which kind of briefly, just as an introduction, and talking, then moving into its role in some psychiatric applications, so that we have the most information about treatment-resistant depression, and as Mark mentioned, that's the focus of my study. And some other mental health applications like aggression and PTSD. And at the end, I'll share a little case report about a child that we met that had an experience with ketamine. So kind of the basics. This medication is a potent, non-competitive antagonist of the NMDA receptor. So the NMDA receptor, that stands for N-methyl D-aspartate. Talk a little bit more about the mechanisms of it. It's FDA approved for generalized anesthesia and procedural sedation in adults. It's actually not approved for children, but it's used very frequently in children. We have a lot of information about it, and I'll maybe just have one slide about that. It causes a dissociative anesthetic state, and it's characterized by preservation of the pharyngeal reflexes. Typically, in order to induce anesthesia, we use doses of 1 to 2 milligrams per kilogram IV, or a little bit higher doses IM. In terms of the pharmacokinetics of this medication, it's extensively metabolized by the CYP450 enzymes, specifically the 2B6 and the 3A4. The primary and active metabolite is norketamine. The medication has a high systemic clearance. It has a short half-life of about 3 hours, and its oral bioavailability is pretty low due to its high first-pass metabolism, about 20%. So in terms of its use in procedural sedation, where it's been, has a much longer standing history than its applications in mental health. Again, it's a dissociative anesthetic. It has this unique feature where it doesn't have respiratory depression, even at the higher doses. It's generally pretty well tolerated, and it's effective for sedation, analgesia, and amnesia. It's contraindicated in children, in young children, and individuals with a history of psychosis. So, featuring some work that Dr. Roback and his colleagues have done, there was a review of a large number of pediatric sedations, over 8,000, and found a pretty low incidence of adverse effects. So, for example, there was about 8.4% of kids had emesis, and this is more likely to happen with higher doses, and the peak was around age 12. So there's an association with age. A similar amount had recovery agitation, most of which was not clinically significant. And about 4% had some sort of airway or respiratory adverse event, and that was also predicted by higher doses, and also with co-administration of cholinergic or benzodiazepine medications. So overall, like I said, it might not be approved for this by the FDA, but we have a very large amount of experience using this medication. It's, I think, very commonly used for procedures in the emergency room settings. So why would we think about or consider using it as a mental health application? So again, this is a potent and non-competitive NMDA receptor antagonist. So this receptor is activated by glutamate, and it's implicated in memory and synaptic plasticity. So glutamate is the major excitatory neurotransmitter in the brain. And the glutamate system has been more and more getting a lot of attention in psychiatry research as being implicated in psychiatric disorders. And the term that's sometimes used to describe this sort of pathological process is excitotoxicity. So sort of too much excitation, excitatory transmission happening that leads to a cascade of neural events and cellular signaling that ultimately lead to toxicity or neural damage and sometimes cell death. So this type of scenario would be relevant to a range of mental health disorders. And it can be initiated or kind of associated with a situation in which there is chronic stress. And most of our mental health disorders are relevant to chronic stress. So depression, post-traumatic stress disorder, anxiety, these all have stress as a major part of the pathophysiology and the cause. So chronic stress is associated with excessive glutamate transmission, and it can lead to toxic changes, and then decreased in the flexibility in the brain, and kind of an impaired neuroplasticity. So what's neuroplasticity? We use this term to describe the ability of the brain to reorganize itself based on experience. So new experiences shaping the way our neural pathways are formed. And this can be reflected in morphologic changes at the level of neuronal processes, so like dendritic branching and things like that. And also in actual just functioning within the synapse. So number of receptors being expressed at the synapse, amount of neural transmission that's happening at the level of the synapse. So these changes can all neuroplasticity, and neuroplasticity is thought to be a good thing. It's thought to be impaired in psychiatric disorders like depression as a result of chronic stress being related to the glutamate system. So here's an example of a recent study kind of looking at this system, and hopefully you guys can see. This is showing neurons in the medial prefrontal cortex in an animal. So the medial prefrontal cortex is a brain region that's really important for regulating emotions and mediating emotion regulation. So here's the control situation, and PFC stands for prefrontal cortex, and they're specifically looking at layer 5. and the pyramidal cell. And here you can see, and this is just a normal situation, and here's a chronic stress situation. So typically it'll involve like some sort of handling of the rat or mouse on a daily basis for 30 days, or that would be a typical stress paradigm, chronic stress paradigm. So you can see that there's significant changes where there's fewer apical dendrites, projections, and they're shorter. There's fewer and they're shorter in length. And then here's just more blown up. Again, here's the control situation, here's the stress situation. So you have a smaller density of the actual spines from each of these. So this is like one of these little processes blown up. So this is what chronic stress does. In the prefrontal cortex, it causes this modulation where there's a reduction in number of dendritic spines and dendritic processes and spines. And this is thought to be overall related to this excitotoxic process. So ketamine potentially could interrupt this and maybe reverse it. And that's where there's a lot of enthusiasm around the use of ketamine in mental health disorders. And again, there's the most information on depression, but I guess the concepts are relevant to other psychiatric disorders as well. So again, so it seems in the research that's been done to date that I'll show a little bit, ketamine can change synaptic plasticity and restore it to normal levels, and it does this rapidly. So it does this within 24 hours. And it also can increase proteins in the brain and the synapse. One specific one is called brain-derived neurotrophic factor, or BDNF, and does this rapidly within hours. And this is an important protein for the health of just neuronal health and maintaining synapses and maintaining the health of the neurons. These are some of the key mechanisms thought to underlie why ketamine might have rapid effects on mental health disorders. So here's an example. So again, remember I showed you that dendrite spine process and how, and this is a different study, but showing kind of a similar thing where here's the control situation, here's a stress situation. You can kind of see there's now a reduction in number of spines and density of spines. And then within 1 day, ketamine reverses this and increases the number of number of spines and density, and so that it looks now more like the control situation. And this is an animal model, and there are several, different types of ways to look at depression-like behaviors in animals. And this particular study looked at two that one was a sucrose preference test, and one was this latency to feed. So they measured it, and so in the control, this is the control, this is the chronic stress, and then you can see the ketamine restored, like, not only the spines, but also the behavior in both situations. So it kind of normalized the behavior and normalized the number of spines. So this type of research has been done by a number of groups now in recent years, and there's a lot of interest, and it does seem like this restoration of these neuronal processes does seem to mediate behavioral changes that underlie, or that are seen with ketamine. Okay, so here's more of a cartoon of a similar thing of what I was just saying. So here's an example of a synapse in the normal state, and here's our these are not NMDA receptors, but they're AMPA receptors, but they're a different type of glutamate receptor. And I guess I won't expect you to absorb all this, and I don't even totally understand it. But what this slide is telling us is that in a stress disorder like depression, there's destabilization of the synapse. So for example, there's these changes in the AMPA receptors in these downstream proteins, in, like for example, GSK3, and then there's another one called mTOR that people have been, these two are ones that people have been really interested in studying as like part of the cascade that ketamine affects. So depression causes these synaptic changes, and then ketamine is able to restore the synaptic stability in the brain. So those are some general principles that might apply to different psychiatric disorders. And again, the first one that was really looked at was depression. So I'll share a little bit of that story now. So the first study that was published was by Berman and colleagues in biological psychiatry 15 years ago now, based on this theory of the glutamate toxicity hypothesis and the NMDA receptor seeming to be really relevant in psychiatric disorders. They tested ketamine as a treatment for treatment-resistant depression and found this really remarkable result, which was that here's placebo, where the people that received placebo basically didn't have any response. On the y-axis, we have depression scores. So this is the Hamilton depression rating scale in this case. And people that received ketamine had this dramatic reduction in depression symptoms that persisted into 72 hours. So this was followed up by a couple other similar studies. Again, and this first study was the dose was 0.5 milligrams per kilogram, and the infusion rate was 40 minutes. And this is kind of one issue that we have in the field right now, is all of the studies since then have been 0.5 milligrams per kilogram, and or most of the published studies, and 40 minutes. So we have most of the information on that particular regimen. So again, another single infusion study with this time, again, placebo, and the placebo, you can see, didn't have any response, and the ketamine group had this dramatic reduction. And this is a little bit bigger group. That first, I don't know if you saw the first study, it had only 7 patients. Now this is 17. They had this dramatic reduction in slow return of symptoms over the course of 2 weeks. So it is persistent. It's not just getting high and feeling better because you're high. The high only lasts, minutes to hours, and this effect lasts for hours to days. Now, this more recent study was instead of a regular placebo, there's a challenge in this research because people want to have a placebo that also has some of the side effects of ketamine. Because if it was just a sugar pill or sugar, saline, you can tell which one is the active drug, because ketamine causes all these effects like being dizzy or having dissociative symptoms. So they, in this particular study, they chose midazolam, which also kind of has a calming and some disorienting effects at least. And they also showed a separation from the control medication, also a single study. So kind of these are the main 3 big studies that have been generated all this enthusiasm about ketamine. And an analysis of these studies, and a few others. So there's been a total of 97 patients in published studies at this point taking ketamine, which is still a pretty small number to generate this amount of enthusiasm. But I don't know if pediatricians can appreciate how significant a problem in psychiatry depression is. So depression, we have some good treatments, but there's a substantial number of people that don't respond to treatment in depression. So maybe 50 to 60% of patients will respond to current treatments in depression. And so we have this leftover amount, and some people have these chronic, severe, refractory courses that are just really terrible. And so if there's something that we can do that's different for these patients, we just get really excited about that. Okay, So the overall response rate was 67%, so much better than, what we currently have with our SSRIs or our CBT, cognitive behavioral therapy as their standard treatment. 2% of the infusions were discontinued due to adverse events, so a really small number. The overall attrition rate was 3%, also really small. The most common adverse effects, and typically these studies would observe them for 4 hours, which is much longer than I know the ER doctors in the front row observe their patients who get much higher doses. Drowsiness, dizziness, poor coordination, blurred vision, and feeling strange or unreal would be the typical effects associated with ketamine. A third of the patients had some sort of hemodynamic changes, so typically increased blood pressure and heart rate. That is transient and goes away when the infusion is over. Some increases in kind of psychotic symptoms or dissociative symptoms, but those symptoms weren't persistent in those cases that did have follow-up information in this study. This is a very recent review. So another thing that that's been generating a lot of interest is not just overall decrease in depression symptoms, but specifically suicidality. So there's been a few different studies, 3 now, really focusing on impact on suicidality, so decreasing suicide thoughts. This first one with an N of 33. It was a single infusion study, and they found that suicide thoughts decreased at the end of the infusion, and the effects persisted for 4 hours. This next study found a similar thing, but they followed the people for 3 days, and so it was persistent. And then this last study, a little bit smaller number, but it was adults presenting to the emergency room with depression and suicide thoughts. They had 1 dose of ketamine, and actually depression and suicide improved within 80 minutes, but were sustained for 10 days. So some of the excitement about the suicide piece is, could this be used as a treatment in the emergency room for suicidal ideation at some point? Could this be a tide over to, typical antidepressant medications take, as you know, many weeks to kick in, and could we use ketamine, as a tide to tide people over to keep them safe until the medication is working, or some sort of treatment model like that? Oh, this is just a depiction from one of the studies showing the they measured suicide thoughts and wish to live and wish to die, every 40 minutes, and you can kind of see it. The wish to live increased and stayed higher. The wish to die decreased and stayed lower. So it's really exciting for people that are interested in wanting to prevent suicide. Okay, so based on these studies, there's still a lot of gaps, obviously. We're still kind of early in the research. These initial studies were all single infusion, same dose, so we don't have information on other doses. They required a washout of other medications, and that requires then a hospitalization typically to keep people safe, and that's really expensive and really can be hard on the patients. And limited follow-up to determine the duration of the effect. So I'll share with you a study that was done by researchers, colleagues here at the U. The PI is Paolo Sharoma, and other people involved were Kelvin Lim and some other psychiatrists in our department and trainees. So this is an open-labeled study at the VA, veterans with treatment-resistant depression. They used the classic dose, the 0.5 milligrams per kilogram over 40 minutes. And this time they wanted to say, can we do better with a series of treatments? So not just one, but we're going to do 6. And they modeled it after ECT. So I don't know if you guys are familiar with electroconvulsive therapy, but it's a treatment available and approved for treatment-resistant depression. So people that don't get better with standard treatments, and that treatment is typically given Monday, Wednesday, Friday for about 8 to 12 treatments. So they kind of use that schedule. So Monday, Wednesday, Friday, 6 infusions only, and they didn't require a washout. They just used it as an adjunct medication. So the patients stayed on whatever they were, entered the study, and then they were followed, the responders were followed for 4 weeks to measure the duration of response. So this was a really encouraging result. So here's a cumulative response graph. So here's like the Monday, Wednesday, Friday, Monday, Wednesday, Friday. And so you can see that as we increase the number of infusions, the percent of responders increases. So if we just did, 1 infusion or 2 infusions, we have less than 50% responders. But by the 6th infusion, 90% of them were responders. So this was just a small study. It was only 11 people, but to me, it was kind of it was important to see, and made me think maybe it's better to do serial infusions and not just one treatment, and maybe we can capture more people with that approach. And then with their recovery, or with their duration of recovery, so they were seen weekly for 4 weeks, and the median time to relapse was 16 days. So it's actually a little bit longer than previously published studies in terms of the duration. Still not great, and I know you're thinking, what are these people supposed to do in the long term? And that's still a really open question. So most of our mental health disorders are not, they are almost all chronic disorders. So depression, post-traumatic stress disorder, these are not one-time things. They're often chronic disorders, and so we need a plan for chronic treatment that we don't have right now. Okay. So what's known in terms of chronic treatment? Basically very little. I found, even just on a very recent review of the literature, just two case reports. One was 2 patients with bipolar 2, so they had depression, but their diagnosis was bipolar 2. They had many medication failed trials, and they both got kind of maintenance treatment with intramuscular ketamine. They didn't report milligrams per kilogram, but the doses were like 50 to 100 milligrams for these patients, and they did pretty well. The second case report is a lady who had treatment-resistant depression, and she also had systemic ovarian cancer. But even before she got the ovarian cancer, she had long-term depression that was chronic and resistant to treatment. And so she was given IM ketamine for 7 months, and she had a good response. And I think that she, in these case reports, they would kind of document the symptoms between treatments, and they both kind of found that the depression symptoms would kind of go up after like 3 to 7 days, and so they'd have to get their treatment. And that's kind of how they determined the frequency. Like, okay, if your depression symptoms are going up again, we'll have to treat again. And so it wasn't, in these cases, it wasn't like do it once and the person's cured forever. It's like they needed ongoing treatment. It's just a few patients. So it's a little bit surprising how little we know about this. There is, I just looked on clinicaltrials.gov, and I could only find one study. It's actually at the Mayo that's looking at maintenance treatment, and this is still in adults. So I still haven't said anything about using this medication in kids. When I first saw this, actually one of the residents presented an earlier version of what I presented with the VA study, and I got really excited about it, and I said, well, what about kids? Depression frequently emerges in adolescence, and it's sometimes even like more of a severe form when it emerges in kids. And we all know that like early intervention, if we can come up with an effective intervention early, we might be better off in terms of the long-term course. And so I felt like this really needs to be looked at in kids, and it hadn't been. So we do have some treatments for adolescents with depression, but they don't always work, kind of similar to the adult studies. So we do, treatment-resistant depression in adolescents is a thing. It does happen, and it's a serious problem because there's long-term consequences like suicide, and chronic disability if kids aren't able to get the right treatment early. Another reason that it's important to study kids is their brains are developing. They might have different biological underpinnings of depression. They might have different responses to medication. Their whole system might be more vulnerable to developing depression or having a weird reaction to a drug, or maybe they're more malleable because of their ongoing developments. Maybe they'll have a better response than adults. So it needs to be looked at separately. So I did find, so there was just this one study looking at ketamine for mood disorders. This is the only publication for mood in general right now. It's a kind of a pilot study. The first author is Dr. Papalos out in New York. And so he had a practice in which he was giving intranasal ketamine to children with bipolar disorder. So he had this thing called, he's described in the literature, fear of harm phenotype of bipolar disorder. So these kids got intranasal ketamine every 3 to 7 days with doses ranging from 30 to 120 milligrams. And he found that a lot of their symptoms improved, aggression, fear of harm, and manic symptoms. And the effects typically lasted 72 to 96 hours and were followed by relapse. So I'll show you the chart from the paper. So these are some of the features of this pediatric bipolar disorder fear of harm phenotype. It's territorial aggression, attention dysfunction, mania, harm to self or others, self-esteem. So these are all things that improved significantly in these 12 kids with the ketamine treatment. So sleep, sensory sensitivity, hypersexuality. I apologize, I don't remember what PPSO stands for, anxiety. And so this was a very interesting paper where a broad range of symptoms are being improved with this particular treatment. And this doctor is prescribing ketamine intranasally to children now, and I know about it because I work with one of his patients. So the use of intranasal ketamine is actually a much newer thing, and it's of high interest because if we could figure out the safety and appropriate parameters, it's so much more practical than doing intravenous infusions, but it's also much less studied. Okay, so this. So here I'll share with you the current study that we are working on here at the U. Like Mark mentioned, this is funded by the CTSI. It's a little K-to-R project, so it's just a small study. The planned N is 10, where we're going to look at, so we're kind of modeling it after that VA study that I shared with you before. So the 6 treatments, the Monday through Friday schedule, Monday, Wednesday, Friday schedule, 0.5 milligrams per kilogram based on ideal body weight. And adolescents with treatment-resistant depression, and that's defined by, it's kind of just similar to what other researchers have done in this area, where treatment-resistant depression is defined by 2 past trials of an antidepressant that didn't get an adequate response. They can still meet criteria for it if they had, let's say, they didn't have the appropriate duration of the treatment, but they had an intolerance to the treatment, so they can still meet criteria for treatment-resistant depression if that was the case. The kids that we end up getting have had many trials, so it's usually not a problem fitting the criteria. We also are really interested in looking at the brain mechanism. So we actually do neuroimaging at the CMRR, and we collect blood before and after the treatment. And I have a collaborator at the Mayo Clinic that helps me. She's really interested in some of those intracellular signaling I was highlighting earlier, like the mTOR and the GSK3 pathway as a result of the NMDA receptor stimulation. Okay, and then we're following them up for 4 weeks as well to look at duration of response. So the progress to date, we've only completed 4, so we're a little less than halfway done. So this study took 6 months to approve. It's a pretty new thing, and so there was some hesitation about it, but it was approved in October of 2014, or sorry, September of 2014, but then it was suspended. So probably people here are aware that all psychiatry drug trials were suspended in March of 2015, kind of in response to the concern about human subjects that was broadly happening at the university, and especially with regard to mentally vulnerable patients like people with mental illness. So all of our studies were halted. We had to submit everything to an external IRB, and they chose this IRB company called Quorum. So we just heard that it was approved by Quorum yesterday, and then minutes before I came over here, I found out that Dr. Herman sent us a letter saying it's okay for you to restart your study. So we're really excited to get the studies started again. So ignore that last bullet point, that was not updated. Okay, so I think I decided to share with you guys some of the preliminary results. Take it with a major grain of salt because it's only 4 subjects. But so far we haven't seen the overwhelming response that has been seen in adults. For whatever reason. So here I'm showing you, in the light blue is the baseline, and these are Child Depression Rating Scale scores, so CDRS. R stands for revised. And so the baseline, and then after the whole 2 weeks of treatments. And so the biggest responder was our first one, but he only responded 33%, and our definition based on all the other studies that have been done, and typically depression studies, is a 50% reduction in depression symptoms, and so he didn't meet our criteria for a response. And so none of these, since our study design was that responders would be followed up for 4 weeks to see their final outcomes, or when they relapsed, none of these were followed up. They just were all determined to be non-responders. So besides the CDRS, we do a couple of more things to get data on how the patients are feeling more frequently during the study. We use the BDI, which is a self-report measure, and the MADRS, Montgomery-Åsberg Depression Rating Scale, which is commonly used in the ketamine studies, which is clinician administered. So here's some of that data. So again, here's our first subject, the one who did the best, and here's his BDI, which is super high, in the high 30s at baseline. This is at the intake appointment, and then he comes in a few days later for his first ketamine infusion, and before the infusion it was really high again. It was 35, but then it was way lower at the almost not a non-clinical level after the infusion. So this is 2 hours after the completion of the infusion. So he did have a really dramatic change. And also the second infusion, you can see he had the light blue, he had super high BDI, and then it was extremely low at the end of that infusion. But then he would come back the next day, and he'd not feel good again. So each time when he returned, it would be high again, including that last day, it was high again. So he had a response, but it just wasn't sustained enough. And we had a similar pattern, but not as dramatic, with the clinician-administered score. The other patients didn't have such. This patient had literally hardly any response, especially according to him. His assessment of the situation was he didn't have much of a response. This particular patient was a little bit more variable, but also tended to not endorse much of a response. And this person had a little bit more. So going from, for example, this particular infusion, she went from a moderate amount to, she changed some on some of the infusions, but ultimately her these are not her primary endpoint, and ultimately she didn't meet criteria for responding either. So interim summary of our study. But basically, in these 4 subjects, the ketamine treatments have been well tolerated. We haven't seen the high rates of response as been seen in adults yet, but we're still early on in the study, and maybe we just got these particular 4 kids, happen to be the non-responders. Some things that could be different, like I said earlier, these are adolescents. Maybe it's just not as good of a treatment in adolescence. Maybe early onset depression is just a more severe form, and they need a different dose. 3/4 of them are from out of town, so it's just a little bit of a different situation. They're staying in a hotel that people have been really interested in our study. Families have heard about ketamine on the radio, and they've been really excited about, and they're kind of coming in looking for a miracle, really, sometimes. That's an exaggeration, but they're really hoping for something to work for their child. And and they're staying in a hotel, and just they're out of their own situation. So that might be a factor. All of the 4 kids that we've looked at have been overweight. Which might be playing a role, maybe even just in the terms of the dose. We're basing it on ideal body weight. I've been worried that maybe we're underdosing them. These are just kind of me scratching my head of what's going on and why aren't we seeing miracles like has been seen in the adult study. But again, big grain of salt because it's very early on. So have to stay tuned for the next steps, which is to finish off the other 6. And then we're really interested not just in looking at efficacy, but also looking at neural changes. And unlike the rat studies that I shared with you, we can't take a piece of the brain and use a micrograph and look at spine density. So we're trying some other approaches. So we're collecting blood, and with my collaborator at Mayo, we are able to look at some of the intracellular signaling in response to ketamine, and we're also scanning them. Oopsies, what happened? That was not such a tragedy. We're also scanning them to look at their connectivity, thinking that the synaptic plasticity is going to be directly related to brain connectivity, and that might be a good index of what's changing at the level of the brain. Okay, I've now been talking, I think, for 40 minutes, so I'll just have the last section is on, if I can make it move, is on application in other mental health areas. So I wonder if I need to. Thank you for your patience. So just really briefly, there's been a more recent interest in PTSD. So there was one paper, very well published, high impact journal looking at PTSD. Unfortunately, it doesn't seem to be advancing anymore very well. I wonder if I should just not do the show. How about this?
Are you just pushing the buttons?
Maybe this one? Okay. Sorry, everyone. Thank you. I was, for some reason, that arrow worked, not the other one. It did work earlier, though. Okay. So this is a randomized, double-blind crossover trial of ketamine. This is, again, this is an infusion study, but the same group is now looking at intranasal as well for PTSD, and they did find a dramatic decrease in PTSD symptoms in this group of adults with PTSD. For ketamine versus midazolam. So some promise in the area of PTSD. Ketamine's been used for aggression as well. I've been hearing that ketamine's been being used in emergency rooms at Hennepin County for dealing with aggression, and I didn't see a lot of publications about it. I saw some case reports. This first one where there was a combative patient, he had these are both actually published from Minneapolis. Yeah, I kind of recognized one of the stories as somebody might have been in my clinic back then. But anyway, the first one was a person, they were both intoxicated. The first person was really combative, and he was known to be HIV positive, and he had cut himself, and it was spewing blood everywhere, and it was pulsating, and everyone was, the team was really afraid for the patient's safety and everybody else's safety. So they sedated him with ketamine, 5 milligrams per kilogram, and had a pretty good outcome. They were able to get his behavior under control, and it was, there weren't any negative outcomes in terms of his vital signs or things like that. Another case report where this man was on the bridge of a highway overpass here in Minneapolis, and these HCMC medics came to the scene and they kind of grabbed him through the fence and sedated him, stuck the needle through the fence and kind of were holding on to him, and it was quite dramatic, but he had a good outcome as well. So maybe. Kind of in the mental health arena. This case report is a case that came to me, I think through the fact that people knew and community practitioners were aware that I was going to be getting involved in this ketamine study. So this family found me with this 7-year-old boy who had a history of significant child abuse, was adopted, but had such significant dysregulation, behavioral dysregulation, that he just kept on being hospitalized and finally had to go into the residential treatment center. So he would have to be held multiple times a day. He was really destructive. He would destroy a room, kick. He would hurt people. Really sweet boy, but really a lot of fear and dysregulation. So he happened to have a tonsillectomy scheduled, and parents had heard on the radio these stories about ketamine and how miraculous it was, and so they asked the anesthesiologist to give ketamine as the sedation, and they kind of were like, well, I don't know if we can do that, and so the parents didn't get the idea that he could, but after the treatment, he went back to the residential center, and for 10 days he was just remarkably different. He didn't have any holds. He didn't have any he still had some irritability, but he didn't have any major episodes of aggression for 10 whole days. And he actually made progress in his therapy and was able to talk about some of the previous experiences and sadness about not being connected with his previous family and just stuff that he had completely not been able to talk about earlier. So it was really remarkable. And then the parents found out that yes, he had gotten ketamine as part of his treatment in the surgery. So then he had another procedure 6 months later. It was an MRI. He needed to get a sedated MRI, so he got ketamine for that. And both times it was just 10 milligrams of ketamine. And this time he had 8 days of similar thing. He was much less aggressive, and he was more receptive and more affectionate with his family, and much calmer and able to work with therapists. So it was really an interesting case, and actually they were interested in looking into maintenance treatment with me here at the university, which we were looking into and weren't able to quite accomplish. So that is currently in press in pediatrics. So last couple of slides. Is ketamine ready for clinical use in psychiatric disorders? So I guess while there are clinicians out there that are saying yes and are actually using ketamine, I think most of the people in our field is saying it's not quite ready. It's still in the early stage of research. There's still major questions that need to be answered before we can really proceed. Most of the studies have shown short-term effects in adults with treatment-resistant depression, fewer studies with PTSD. It seems like serial dose strategy might be superior to single dose, and we just have such little data on long-term treatment, which is such a needed area because, like I mentioned, most of our disorders are chronic illnesses. And we don't just give Prozac once. We expect people to take Prozac for months to years. And then we just have such little data yet on ketamine for children and adolescents. Basically, our case report and that study that I shared with you by Dr. Papalos are kind of the only ones out there. So just final thoughts. Ketamine appears to have some promise as a rapid antidepressant for adults with TRD and might have other implications in a broader array of mental health problems. A key mechanism appears to be ketamine's impact on reversing the damage caused by chronic stress to restore synaptic plasticity, and in particular in the prefrontal cortex. And additional research is needed to address the current gaps. So long-term use and the need to test the treatment in children. And that's all I have, and I can take some questions. Thank you.
Thank you, Katie. Do we have questions from the group? Dr. Neglia?
Oh, great.
So, Katie, you're doing MR imaging on the patients in your trial.
Yes.
And you're doing functional MRI. You're doing MR SPECT as well?
We are not doing spectroscopy. We have done that in previous studies, and it was kind of I end up choosing not to do it because of just the length of the overall protocol. So we're collecting structural, a resting state fMRI, a task, and diffusion tensor imaging.
I was just kind of wondering if there was a SPECT. You can see a lot of metabolites, and I was wondering if there was a particular phenotype you might see in responders, adult responders, that you don't see repeated in the kids that aren't responding.
Yes, that would be fantastic if we were able to find that. That hasn't been published in adults yet. And I was thinking initially we would definitely include spectroscopy because you can actually measure glutamate. But the problem is it's hard to separate glutamate from glutamine in the data, in the spectroscopy data. And there's a lot of questions in the field right now. It's a little bit controversial. When we measure concentrations of glutamate in, a voxel that's, several centimeters in each direction, are we seeing intracellular glutamate? Are we seeing extracellular glutamate? And the question is really important in terms of, transmission and how we understand the pathophysiology. And so it's hard to interpret the results. So that was kind of one of the reasons we ended up moving away. But yeah, that's really one of the huge things that we'd like to see with some sort of neuroimaging biomarker, or maybe one of the blood biomarkers is, can we have some sort of predictor of who's going to respond and who's not going to respond, and what and why. Mm-hmm.
Katie, I'm really interested in dose, and it seems like, the younger you are, the faster you metabolize ketamine, and maybe a higher dose or maybe a shorter infusion time would change your results. What do you think?
So that's a great question, and like I kind of was alluding to, that we have a dearth of information on that in psychiatry. My understanding is there's current work at the NIH now looking at dose response, so trying a range of doses and seeing, and that was one of my fears. And when I'm looking at our 4 non-responders, is maybe I underdosed them and I don't have a flexibility in my protocol to increase the dose. But maybe because they're younger, they need a higher dose, and maybe because they're overweight or different things. So I think in the next study, we need to have an ability to look at that.
All right. Well, thank you very much.